Good afternoon. In our last lecture, we completed the flexor muscle group of the forearm, which includes superficial, intermediate, and deep muscle. Today, we'll go into the extensor muscle group. They are also act as extensions for the wrist and the digits. It's a compromise of 12 group of muscles. Today, now we are diving into the extensor compartment of the forearm, which homes to 12 key muscles responsible for extending the wrist, fingers, and thumb. These muscles originate mostly from the lateral epicondyle of humerus and are innervated primarily by the radial nerve. So these 12 muscles we can group into four functioning groups. So we'll starting from the carpi muscles. These carpi muscles are the wrist extensors. They are extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris. So this is our carpi muscle group. Extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi ulnaris. So these muscles are the wrist extensors. So extensor carpi radialis longus extend and abduct the wrist. Extensor carpi radialis longus extend and abduct the wrist. Then external carpi radialis brevis also extend and abduct the wrist, but shorter and deeper than the extensor carpi radialis longus. Next, we will go to extensor carpi ulnaris. It extends and abduct the wrist. So now we know there are three muscles in the carpi muscle groups. They are namely extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi ulnaris. So these three are basically wrist extensors. Extensor carpi radialis longus, it extends and abducts the wrist. Extensor carpi radialis brevis also extend and abduct the wrist, but they are shorter and deeper than the ECRL. And extensor carpi ulnaris extend and abducts the wrist. Now we can go into the next group is the pollicis muscle group. There are three muscles in this group also. So starting from abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus. So abductor pollicis longus, extensor pollicis brevis, and extensor pollicis longus. So they are considered as thumb extensors. Abductor pollicis longus abducts and extends the thumb at the metacarpal joint. So carpometacarpal joint. So extensor pollicis brevis extend the proximal phalanx of the thumb. Extend the proximal phalanx of the thumb, while extensor pollicis longus extend the distal phalanx of the thumb. So now we have completed three muscles from the carpi group and three muscles from the pollicis group. Pollicis means they are abductors of the extensors of the thumb. So now we are going into next muscle group, digits. So this digit muscle group, there are three muscles in the same this group also. They are extensor digiti communis, extensor digiti minimi, and extensor digiti indicis. So now we have three muscles in the extensor group of digits. So digit muscles are extensor digit communis. So this extensor digit communis is the main extensor of second to fifth digits, and extensor digiti minimi specifically it's extend the fifth digit or the little finger, and indicis muscle is the index finger extensor. So it's extend the index finger independently. Index finger and the fifth finger has independent movement compared to other two digits. So next we will go into other group. Other groups, they are considered as supportive muscles. They are brachioradialis, supinator, and anconeus. So though this brachioradialis located in the extensor compartment, it flexes the forearm at the elbow. So, and supinator doing the supination of the forearm, and anconeus assists the elbow in extension and stabilize the joint. So coming to clinical relevance of this muscle group, overuse of these muscles, specifically the wrist extensors, can lead to lateral epicondylitis, commonly known as tennis elbow. So understanding their anatomy is crucial for diagnosing nerve injuries, specifically involving in radial nerve. So here I can give you a mnemonic to remember your abductor muscles. A pretty long beautiful lady. A pretty long, a pretty long beautiful lady. So a pretty long beautiful lady means abductor pollicis longus, a pretty long, a pretty extensor pollicis brevis is beautiful, and lady use the pollicis longus. So this is this mnemonic you can remember to abductor pollicis muscles. So pollicis muscles are, there are three: abductor pollicis longus, extensor pollicis brevis, and extensor pollicis longus. So these 12 muscles work in harmony to allow precise and powerful movements of the hand and wrist. Their coordination is essential for everything from typing to throwing ball. So now we'll go into each muscle's location and their uh, direction, insertion, and the origin. So we'll go into one by one. Extensor carpi radialis longus, also abbreviated as ACRL. This is one of the key muscles in the posterior compartment of the forearm, and it plays a vital role in wrist movements and stabilization. Understanding its anatomy is crucial not only for clinical diagnosis but also for interpreting cross-sectional imaging and planning radiotherapy. ECRL originates from the lateral supracondylar ridge of the humerus, just proximal to the lateral epicondyle. This origin is superficial and easily palpable, making it a common site for tenderness in lateral epicondylitis, also known as tennis elbow. It is important to distinguish this origin from that of the extensor carpi radialis brevis, which arises more distally. The muscle inserts into the base of the second metacarpal on the dorsal surface. This long trajectory allows to span both elbow and the wrist joints, contributing to its dual role in extension and radial deviation. On imaging, this insertion is visible as a thin tendon crossing the wrist joint and attaching to the radial side of the hand. ECRL is innervated by the radial nerve, specifically the C6 and C7 spinal roots. This is clinically significant. Injury to the radial nerve, whether from humeral subfracture or compression, can lead to wrist drop due to loss of extensor function of the wrist. ECRL is often spared in low radial nerve lesions because its innervation arises more proximally. So the primary blood supply comes from the radial artery with additional contribution from branches of the brachial artery. This vascular pattern supports the muscle's endurance during repetitive wrist movements. In trauma or flap surgery, preserving this supply is essential for healing and the function. Functionally, ECRL extends the wrist and contributes to radial deviation, means it pulls the wrist toward the thumb side. It works synergistically with ECRB and antagonistically with flexors like flexor carpi ulnaris. During gripping, ECRL stabilizes the wrist in extension, allowing the fingers flexor to act more efficiently. ECRL is implicated in lateral epicondylitis due to overuse, especially in athletes or manual workers. It also a key landmark during radial artery cannulation, particularly in trauma, sit-in or ICU procedures. In radiotherapy planning, understanding its location helps to avoid unnecessary exposure and to preserve the function. On MRI or cross-sectional CT, ECRL lies lateral to brachioradialis and superficial to ECRB, extensor carpi radialis brevis. It appears as a fusiform muscle in the proximal forearm and tapering into a long tendon distally. Recognizing its position is helpful when evaluating soft tissue injuries or planning radiotherapy fields for forearm tumors. To summarize, ECRL is a long, superficial forearm extensor that plays a key role in wrist mechanics and clinical interventions. Its anatomy, innervation, and vascular supply make it a muscle of interest across orthopedics, trauma, and radiotherapy. Let's focus on one of the key wrist extensors, the extensor carpi radialis brevis or ECRB. This muscle plays a vital role in wrist movements and is clinically significant due to its involvement in common overuse injuries. ECRB originates from the common extensor tendon which attaches to the lateral epicondyle of the humerus. This shared origin is important. It's also the site for several other forearm extensors, making it a hotspot for strain. It inserts on the posterior aspect of the base of the third metacarpal. This placement allows it to exert force directly on the wrist, contributing to extension and stability. Functionally, ECRV helps extend the hand at the wrist joint and also contributes to abduction of the hand. It works alongside extensor carpi radialis longus, but ECRV is shorter and lies deeper. ECRV is often implicated in lateral epicondylitis or tennis elbow, a painful condition caused by repetitive wrist extension. Understanding its anatomy helps in diagnosing and treating this condition effectively. Now let's move to the extensor carpi ulnaris, another key player in wrist extension and ulnar deviation. Extensor carpi ulnaris, it originates from 2 points, the lateral epicondyle of the humerus, which is a common extensor origin, and the posterior border of the ulna, giving it a strong anchor for pulling the wrist backward and ulnar deviation, ulnar side. Its insertion is at the base of fifth metacarpal bone, which aligns with its role in ulnar deviation. You can palpate its tendon just medial to the extensor digitorum when the wrist is extended and deviated to ulnar side. Functionally, it's crucial for stabilizing the wrist during gripping, especially in forceful or repetitive tasks. Think of hammering or using a screwdriver. This muscle helps maintain the wrist position during these maneuvers. It's innervated by the posterior interosseous nerve, which is a deep branch of radial nerve. This is important clinically, especially in cases of radial nerve palsy when there is compromise of wrist extension. In lateral epicondylitis or tennis elbow, this muscle may be involved due to its common extensor origin. We have looked at the three carpi muscles: extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris. Each contributes to wrist extension, but with directional nuance. The radial extensors assist in radial deviation, while ECU supports ulnar deviation. This image beautifully illustrates their anatomical layout and functional synergy. You can see how they flank the posterior forearm, working together to stabilize and mobilize the wrist during tasks like lifting, gripping, or typing. In radiotherapy positioning or surgical preparation, wrist alignment is critical. These extensors help maintain neutral or extended wrist posture, minimizing strain and optimizing access. So, whether we are assessing a patient's grip or planning a forearm block or teaching students about upper limb mechanics, the wrist extensors are central to both movements and clinical insight. Let's now consolidate our understanding of the three key muscles that control thumb movements from the posterior forearm, collectively referred to a group as pollicis group. First, the abductor pollicis longus, APL. This muscle originates from the posterior surface of the radius, ulna, and interosseous membrane. It inserts at the base of first metacarpal and functions to abduct the thumb at the carpometacarpal joint. Next, the extensor pollicis brevis (EPB). It lies just medial to APL and shared similar origin. Finally, the extensor pollicis longus (EPL). This muscle originates from the posterior surface of the ulna and interosseous membrane and inserts at the base of distal phalanx of the thumb. Together, these three muscles allow for precise thumb movement and thumb control, essential for tasks like pinching, gripping, or hand manipulating of the objects. Their anatomical arrangement also makes them clinically significant in in conditions like tenosynovitis, scaphoid fracture, or radial nerve palsy. Understanding their coordinated function helps us to appreciate the complexity of the thumb movement. And please remember the mnemonic I mentioned earlier also, a pretty long, beautiful lady. Let's now look at the abductor pollicis longus, APL, a deep forearm muscle with a specialized role in thumb mobility. It originates broadly from the posterior surface of radius, ulna, and interosseous membrane, which it is giving it a strong, stable base for action. Its insertion at the base of the first metacarpal bone allows it to pull the thumb away from the palm, a movement we call abduction at the carpometacarpal joint. Functionally, APL is key for thumb positioning, especially during precision grip. Think of a holding a pen or pinching a suture needle. It also assists in thumb extension and contributes to radial deviation of the wrist, working synergy with the wrist extensor muscles, radial extensors. So clinically, it's one of the two tendons forming the lateral border of the anatomical snub box alongside the extensor pollicis brevis. This region is important in physical exams, especially when assessing scaphoid fractures. APL also plays a role in recovering tenosynovitis, a painful condition caused by inflammation of first dorsal compartment. Patients often present with radial wrist pain, especially during thumb movement or gripping. From a radiotherapy or surgical preparation perspective, understanding the cause of APL helps in preventing position the hand and wrist to avoid tendon compression and assure anatomical clarity. So while it's a deep muscle, its impact is quite visible especially in thumb function. Continuing with the thumb extensors, let's focus on the extensor pollicis brevis or EPB. This muscle originates from the posterior surface of the radius and the interosseous membrane, placing it just lateral to extensor pollicis longus. It inserts at the base of the proximal phalanx of the thumb, allowing it to extend the thumb at the metacarpophalangeal joint. It also assists in abduction at the carpometacarpal joint, working alongside the abductor pollicis longus. EPB is one of the two tendons that pass through the first extensor compartment beneath the extensor retiniculum. This anatomical detail becomes clinically important in conditions such as recurrent tenosynovitis, where inflammation of this compartment leads to pain during thumb movement, especially in activities like lifting a child or gripping a tool. It's innervated by the posterior interosseous nerve, a branch of the radial nerve, which also supplies the other deep extensors of the forearm. In surface anatomy, EPB contributes to the lateral border of the anatomical snub box, a region we palpate when assessing for scaphoid fractures. During resisted thumb extension, its tendon becomes visible just lateral to the EPL. Functionally, EPB is essential for precision grip, texting, and fine motor control. All movements that rely on coordinated thumb extension. Let's look at the extensor pollicis longus or EPL. It plays a vital role in thumb mobility. It originates from the posterior surface of the middle third of the ulna and adjacent interosseous membrane. It inserts into the dorsal surface of base of the distal phalanx of the thumb. This long path gives it a leverage for powerful extension. So when discussing the innervation of this muscle, it gets innervated by the posterior interosseous nerve, a continuation of the deep branch of the radial nerve. This is important when assessing radial nerve injuries, as thumb extension is a key test. Coming to the action of the EPL extends the thumb at three joints, namely interferential joint and also carpometacarpal joints and metacarpophalangeal joints. So extension of all three joints, and also assist in the radial abduction of the wrist. So it's not just about the thumb. Other important point is EPL forms the medial border of the anatomical snub box. So while lateral border are formed by the extensor pollicis brevis and abductor pollicis longus. This region is clinically important for the palpation of the scaphoid and assessing scaphoid fractures. Okay, now we explore the extensor digitorum communis, the primary extensor of the digits 2 to 5. So it's central to coordinated finger movements and frequently involved in clinical pathologies. EDC originates from the lateral epicondyle of the humerus. That means it's a part of common extensor origin. Its tendons insert into the extensor expansion of the middle four fingers, forming the dorsal digital apparatus. This EDC forms the dorsal digital apparatus. And what about the innervation? It also from the innervated by the posterior interosseous nerve, a branch of radial nerve. This innervation is crucial in assessing radial nerve injuries, as this finger drop is a classical sign for the radial nerve injuries. EDC extends the metacarpophalangeal joints of digits of which digits? Second to fifth digits. So via the extensor hood, it assists in extensor of the extensor of the PIP and DIP joints. So it goes and join with the extensor hood. So it also contributes to wrist extension, but it's a weak wrist extensor muscle. An EDC tendon passes through the fourth dorsal compartment in the wrist alongside the extensor indices. This compartment is common site for tenosynovitis, especially in overuse syndrome. So conditions like extensor tenosynovitis. EDC is often implicated in lateral epicondylitis. We also know it's share the common extensor origin. So this may play a role in tennis elbow. And especially you should remember condition like in rheumatoid arthritis, this EDC tendon may rupture suddenly from accretion over the distal ulna, causing to a sudden finger extension loss. And this EDC tendon clinically again important for us, as we can use this tendon for reconstructive surgeries, especially like condition like radial nerve palsy. So to restore extensor mechanism, we can use EDC for tendon transfer procedure. In radiotherapy, you should remember this point, as EDC is a superficial muscle. So its superficial location makes it vulnerable to fibrosis. So contusion must preserve the tendon integrity. So on MRI or CT, EDC is visible in the dorsal wrist and hand. So you have to track its cause for contouring in the dorsal hand irradiation. Understanding the extension hood anatomy helps in planning soft tissue margins and avoiding functional deficit. So finally, this EDC is more than just a finger extensor. It also plays a role in other hand function and frequent site for pathology. Okay, now let's go into two specialized finger extensors, extensor digita minimi and extensor indices. Though they are small, they play a very important role in fine motor control and are important in both surgical and radiotherapy planning. Extensor digita minimi originates from the lateral epicondyle of humerus, means common extensor origin, and it insert into extensor expansion of the fifth digit. So extensor indices originated from the posterior surface of distal ulna and adjacent interosseous membrane, and its insertion into the extensor expansion of index finger. So what does it mean? EDM originates from the lateral epicondyle of humerus, and the extensor indices originate from the distal ulna posterior surface and adjacent interosseous membrane. So and their insertion into extensor expansion of the digits respective fifth and second digit. So These insertion allow for isolated extension of little finger and index finger. So it gets the innervation from the posterior interosseous nerve, same supply from it's a branch of radial nerve. So this shared innervation is relevant in radial nerve palsy. So finger extension deficits can help to localize the lesion. So EDM, extensor rigidity minimi, extend the fifth digit at all joints, MCP, PIP and DIP, and assist in wrist extension also. Extensor indices extend the index finger independently. So you can extend the index finger independent and also contributes to wrist extension. This independent is clinically useful while extensor indices allow isolated index movements which helps differentiate tendon or nerve injuries. So index finger has isolate extensor movement and your fifth finger also have its isolate index extensor movements because of this specific insertion of the tendons and the nerve innervation. So EDM passes through the fifth dorsal compartment in the wrist and extensor indices passes through the fourth dorsal compartment and it's pass alongside the extensor digitorum communis. These compartments are key landmarks in dorsal wrist surgeries and imaging. So what are the clinical relevances here? EDM is vulnerable in dorsal wrist trauma and may be affected in rheumatoid arthritis. Extensor indices is commonly harvested for tendon surgeries, tendon transfer procedures, especially to restore thumb extension in radial nerve palsy. So isolated index extension via extensor indices is a useful clinical test in differentiation nerve lesions. When we are discussing about radiotherapy, these both tendons are superficial and must be considered when contouring dorsal hand fields to preserve their function. Brachioradialis and conius and supinator. This trio of muscles may not dominate the forearm visually, but they play a crucial role in elbow and forearm mechanics. Each contributes uniquely to movement stability. So especially in trauma and nerve entrapment and radiotherapy contouring, we should consider their anatomy. So brachioradialis originate from the lateral supracondylar ridge of humerus and insert into distal radius, the styloid process of the radius. It's the only forearm flexor innervated by the radial nerve and it's most active when the forearm is in mid pronation. So think of lifting a cup. At that moment, this most action of the brachioradialis dominates while you are in your hand in mid pronated position. So then Anconeus arises from the lateral epicondyle of humerus and insert into the lateral olecranon and proximal ulna. This anconeus is a very small muscle, but it stabilizes the elbow during extension and pronation. So even it's a small muscle, it's helped to stabilize the elbow during extension and pronation. Then other muscle is supinator. It has a broad origin. It's originated from the lateral epicondyle, radial collateral ligament, and angular ligament, and also supinated crest of the ulna. So this muscle wraps around and insert onto the proximal radius. So this spiral-like insertion allows it to rotate the radius during supination, especially when the elbow is extended. So when elbow is extended, it can supinate the forearm. So all three muscles are innervated by the branches of the radial nerve. So all three muscles get the innervation from the branches of the radial nerve. So brachioradialis flex the elbow, particularly when the forearm is in neutral, either pronated or supinated fully. Anconeus assists the elbow extension and stabilize the ulna during forearm rotation. So it's assist in elbow extension and stabilize the ulna during forearm rotation. Supinator is the primary supinator of the forearm when elbow is fully extended, while also complementing the biceps which dominates when the elbow is flexed. So bicep do the maximum job when elbow is flexed, and when elbow is extended, supinator plays the key role. To conclude our exploration of forearm extensors, we turn to these axial MRI slices of the wrist joint, a powerful visual that brings our anatomical discussion into clinical focus. So here this image captures the complexity and elegance of tendon architecture at the distal forearm, where muscular effort is translated into the fine motor control. So we'll see the overview of the forearm extensors here. This is an axial cut of MRI of forearm. So here we see the key extensor tendons arranged dorsally. Here see these extensor tendons all arranged in the dorsal. This is your dorsal area. This is your volar. Volarly you can see the flexor tendons, and dorsally you can see the extensor tendons. So each occupying their defined compartment. So starting from the extensor carpi ulnaris, this is your extensor carpi ulnaris, which lies just adjacent to ulna at the most medially, stabilizing the ulnar side during wrist extension and the supination. So this ECU lies the most laterally at the ulnar side So it stabilize the ulnar side during wrist extension and supination. So on. Next, the extensor digiti minimi and extensor digiti communis. So here, extensor digiti minimi, you can see here, extensor digiti minimi, close to the extensor digiti minimi. This is extensor digiti communis, which is fan shape with fan out towards the digits, enabling coordinated finger extension. You can see this has been fan out tendons. After that you will see extensor pollicis longus. So it curves obliquely across the wrist, forming the medial border of the anatomical snub box, clinically relevant in scaphoid fractures. So laterally, what we can identify is, so here we see extensor pollicis longus. So laterally we can identify extensor carpi radialis brevis and extensor carpi radialis longus. These two tendons, these are in lateral area. This is your medial side, this is your lateral side. Extensor carpi radialis brevis and extensor carpi radialis longus you can see in lateral side. So they are key players in wrist extension and radial deviation. So also we can see there are some specific extensors which are we call pollicis group. The image shows highlights also extensor pollicis brevis. This is your APV, extensor pollicis brevis, and extensor abductor pollicis longus. They are specifically coordinating and crucial for thumb mobility. So they are also forming the lateral border of the anatomical snub box. So their proximity to the radial styloid makes them vulnerable in, as we mentioned earlier, they are vulnerable to inflaming condition called dequerent thinner synovitis. It's a common overuse syndrome. So, though our focus was extensor tendons, here we can see flexor tendon also, which are lies in the volar compartment. So here you can see ventrally what flexor carpi ulnaris, flexor digitorum profundus, flexor digitorum superficialis. This is your palmaris longus small tendon, flexor carpi radialis, flexor pollicis longus. So they are our wrist flexors. So this contrast reinforces the layered complexity of the wrist anatomy, where flexors and extensors operate in harmony across the compartments. So from a radiotherapy perspective, this image is invaluable for contouring. Each tendon must be respected to preserve post-treatment functions. So in surgical planning, especially for dorsal wrist approaches, understanding this arrangement and their relationship between these tendons helps to avoid iatrogenic injury and guide tendon repair and transfers. So with this final slide, we have bridged muscular anatomy with imaging and their clinical relevance and how they are important for therapeutic planning. So now we are coming into end of the forearm anatomy. Thank you.